Welkom allemaal bij deze podcast. Vandaag heb ik een hele interessante gast, namelijk John Bockmann uit Amerika. Hij is een gezagsvoerder in het Amerikaanse leger en werkzaam op dit moment als physician assistant, dus een artsassistent. En hij heeft een tijdje geleden de stoute schoenen aangetrokken door een neurowetenschapper, namelijk Stuart Derbyshire, eigenlijk aan zijn hemd te trekken en hem wat te bevragen over een belangrijk onderwerp waar hij een specialist in is, namelijk fetale pijn. Ze hebben samen toen een essay geschreven waarin eigenlijk wordt gesteld, dat is in 2020 uitgekomen, dat de eerdere gedachten en aannames over fetale pijn eigenlijk heroverwogen moeten worden, omdat de oude aannames niet langer meer te verdedigen zijn. Even om te verduidelijken, die zijn 24 tot 26 weken was ongeveer de grens waarop men zei, dan pas is het mogelijk om fetale pijn te voelen. Dat is nu verlaagd naar 12 tot 18 weken, mede door het essay, een concluderend essay eigenlijk van deze twee onderzoekers. Ik heb al eerder gesproken met hem via de e-mail en nu ben ik erg blij hem te spreken in het echt. Dus we gaan snel beginnen met het gesprek. John, how are you?
I'm well, thank you, Chris. Good to see you.
To see you too. Welcome to the podcast. We've had a few wonderful exchanges through email, in which I've basically conducted an interview with you on the topic of today, which is fetal pain. And you gave me so much information that I just felt that it was we couldn't really exhaust the topic. There's so much to talk about when it comes to that. And you've done a lot of research on previous studies on this matter. And well, let's talk about that today. First, if you could introduce yourself a little bit. I already told them that you're a captain in the U.S. Army and a physician assistant. How did that come about in your life to have those functions?
Well, thanks, Chris. Yeah, I'm an Army captain and a PA, we call it here in America. I took a long route to get here. I didn't actually enlist in the Army until I was 31. So I'm 46 now. So I've been in the Army about 15 years. And I started out as a Black Hawk mechanic. So previous career as a teacher, a writer, quit being a teacher to go to civilian flight school, got a commercial pilot's license and a bunch of other stuff. Was planning to go into aviation civilian-wise. But long story short, I always had a real affinity for and a curiosity about the human body. Always was raised to believe that caring for one's fellow man was the highest purpose. And so after a time, I saw an opportunity to become a PA in the Army, and it was free. They paid for it. So I took it, and I got accepted. And so that was back in 2015. So I've been in PA school 2015, 2017, and here I am as a PA now for about 3 years.
Right. Okay. Very interesting. And I understand you just came back from Afghanistan?
I did, yeah. About 8 or 9 months over there in Afghanistan, over in Kandahar.
Wow. Okay. Well, much respect to you, sir. So after a while, after you became a PA, you started to investigate fetal pain, and then you stumbled upon a big name in the neuroscience field, you might say, Stuart Derbyshire. And somehow you felt the need to contact this person. How did that come about?
Yeah, early on, good question. So early on, Chris, we had to choose our thesis topic. It's a master's degree level for us here in the United States. A master's degree requires a thesis. And so early on in my training as a student, a PhD student, we had to select our thesis topics. At first, mine was obesity. But then David Daleidin's Planned Parenthood undercover videos came out. And as the father of 2 young daughters at the time, ages 1 and 3, I think it was, and these things really hit me. First of all, they were so gory and so callous. And I couldn't help but see my 2 young daughters in each of these videos in these torn bodies. One of the physicians on the videos called them war-torn. And that really hit home because it occurred to me, Chris, that these could have been my daughters, a smiling, urbane, highly educated physician in medicine, the career in which I was about to take part would have done this to my daughters for a fee. And it really smacked me. So I was wondering, hey, some of these kids aren't that, some of these fetuses are not that tiny. I wonder if they could feel the pain, because a lot of fetal pain legislation was coming about that time. So that's what got me started on that thesis topic.
Right. Okay. So what happened when what did you expect to find when you contacted Stuart Derbyshire, and what was it about? What was your basic question to him?
Yeah. So by the time I contacted him, so the videos came out around July 2015. I contacted Stuart in May 2016, and this was as a result of many articles that I had seen from Stuart on the topic of not just fetal pain, but pain in general. He was cited on almost everything to do with pain. He was one of the primary deniers of fetal pain. He'd also written Royal College of Obstetricians and Gynecologists 2010 study on fetal awareness, denying fetal pain until at least 24 weeks and possibly ever. And so I knew which camp he was in, and he was pretty. I would almost characterize him as pugnacious. So when I saw an interview in the New York Times 2013, I believe it was, him quoted saying that one of the main points of the ARCOG 2010 study didn't quite work anymore, that kept bothering me. And I couldn't get over it. I was about to have to turn in my thesis in a month or so. And so I just thought, well, okay, I'll contact him and see what he meant by this. So that's how we got into contact. And I didn't expect him to write back, but the very next day there it was in my email inbox. And so that started a multi-year conversation.
Right. Now you expressed that you felt that the ARCOG was flawed in some ways, the study. And for people at home, that's a study that basically, as many studies, I think, concluded that fetal pain was not possible before 24 to 26 weeks. Am I correct? And,
yes, 24 weeks in this.
24 weeks. And so what were your biggest concerns about this study, about how it was conducted?
So their research was thorough, and their presentation was impressive. And it was produced by a large group of very highly qualified individuals in the UK. So to take nothing away from that. What bothered me was the basis for their study. And that was in their introduction to the study, it says something like, as most neuroscientists believe that the cerebral cortex is required in order to feel pain, and that cerebral cortex is not engaged, is not functional before 24 weeks, it can be concluded that no pain can be experienced before this gestation, that is 24 weeks. So that was the first point. And so what struck me about that, first of all, was that they appealed to consensus, saying that as most neuroscientists believe no pain before this time period, 24 weeks, then it can be concluded that there's no pain before this time period.
Right.
So it seemed to obviate everything that came after that. That is, why even bother to write anything after that point? Because they're claiming authority of some supposed consensus, and they don't bother to substantiate consensus, and they don't say why. So they don't say why neuroscientists believe that. And they just think that the cerebral cortex is required for pain perception, and that was not at all uniform. Not all neuroscientists believe that. It's more interesting to me why they believe that than that they believe. That makes sense.
Right. Okay.
Yeah.
So you mentioned the cerebral cortex, and that a lot of scientists, or at least a big chunk of them, believed that this was absolutely necessary in order to feel pain to begin with. Now, why is that no longer a feasible position, according to you and both you and Stuart Derbyshire?
Well, so we've always had some indication that it was not necessary. The work by Bjorn Merker, there was a 2006-2007 study that he came up with, is pretty impressive about basically these children who didn't have cerebral cortexes at all, maybe just a little bit, but they were still able to perceive things, interestingly enough. And so his conclusion was that our treatment of these children was probably not what it should have been, with concerns for how we treat them. We treat them like objects, maybe, or we perceive them as objects rather than human beings.
Right.
That was the first one. Sunny Anand, KJS Anand, is another. He's a pediatric anesthesiologist. He's now at Stanford. He did some work on that as well. He didn't think that the cerebral cortex was necessary. He did cite Bjorn Merker in that, and he testified before Congress a lot. So I relied on their work at first. So basically, the thalamus and maybe a structure called the subplate, which is sort of a precursor for the cerebral cortex, they think may be adequate to enable the perception of fetal pain.
I see. All right. So once you figured out, like, okay, the cerebral cortex is not necessary, does that open the door for this whole new ball game, basically? How do you where do you land after that in terms of the week in which fetal pain might be possible?
Yeah, so it does not. Right. So it does not seem that the cerebral cortex is necessary. It does have an analog, as I mentioned, in the subplate, the cortex-like structure that arrives earlier. And the first, what we call projections, nerve fiber projections to the subplate, begin to emerge around 12 weeks. So that represents to Stuart and me the earliest conceivable time of fetal pain. Now, we recognize that there are some other possibilities, some other indications that maybe the cortex is necessary. But I would say that 12 weeks with the earliest emergence of those projections into the subplate would represent the earliest arrival of pain.
Right. So that's a really big pushback, you might say, from 24 weeks all the way down to 12 weeks. When you both wrote your essay and it was published, I followed it, and I noticed a lot of pro-life organizations clinging to it. Some of them maybe going a little bit too far with the conclusions coming from your essay. But another thing that struck me was the absolute silence on the pro-choice side, as if Stuart Derbyshire now suddenly was not maybe this a kind of a whale in neuroscience. How do you explain that, if you can?
It's not surprising to me at all. First of all, let's just say the silence on the part of the pro-choice side. I noticed early on in the Daily Mail article in January around, it's almost been exactly different. It came out on the 15th of January, and the Daily Mail posted something on that shortly after, and they quoted one of the spokespeople for a British, I think it's the BPAS, saying that this study doesn't change anything in their approach. And the only question is, why wouldn't it? I think it should. So obviously it's uncomfortable, and when we're talking about how scientific theories change, they don't often go easily, and nobody changes their tightly held beliefs easily or without a fight. And I think nor should they, because those beliefs are who we are. And if we were to change who we are all the time dramatically, I think that we would cease to really be anything. Right. So people don't give up their beliefs without a fight. So that completely explains to me why the pro-choice side would be silent. It also explains to me why we would cling to it on the pro-life side. You and I both agree, and I think most people on the pro-life side would agree, that fetal pain doesn't make any difference as to the moral permissibility of abortion. It doesn't play into that at all. But what it does do is it directly contradicts the lie that the human fetus is not a human being like you and I are. And so I think dehumanization has been a primary tool of really bad things done people for human history. And so we're really trying to point out the humanity of the fetus.
Exactly. Right. Well, speaking of the field of neuroscience and also the abortion practitioners not changing their views according to this essay, that reminds me of a doctor you just mentioned, Mr. Anand, who had kind of a similar breakthrough, if not a bigger one, maybe even, I think in the 80s, where he had basically, well, I don't know if you could say, yeah, he's probably kind of a pioneer in the idea that infant children, so the newly born children, could feel pain, which was something that they also did not believe was possible, or at least was not essential for their well-being. So I found that interesting because I didn't really know about that. I thought that it was kind of evident that born children after 9 months, they're born, they could feel pain like we do. This is a logical thing to think, I guess. But it struck me that until the 1980s in the Western world, we were operating on them if they needed surgery without any anesthetics. And Ms. Dr. Anand was, I believe, the first one to say, well, that's wrong, because he saw them coming back from surgeries in total shock sometimes. And his work then, he did some tests, I believe, changed the field, changed how they practiced. And so it wasn't really easy for them, I guess, in the same sense as now. But they did relatively quickly change their view. So how come in this case it's not? Is it more politicized, abortion, so that they are slower to the new ideas and to the acceptance of that?
Yeah, good question, Chris. I think that there is some ideological resistance to the idea for obvious reasons. So two things. One, Sonny Anand, his study, and then two, the universal practice in fetal surgery for therapeutic reasons. They give anesthesia to the fetuses from the earliest gestations on which they were born. Yeah. So the only time that we are aware of, the only case in which we're aware of that fetuses don't get anesthesia for surgery is during abortion. And I think that's a big reason for digging in the heels here. There wasn't so much a resistance for that reason back in the mid-80s when it was coming out with Sonny Anand. Jeffrey Lawson was the newbie, the preemie, I should say, the newborn, who received surgery without anesthesia. And his mom found out about it, found out this was not only a common procedure, this was the standard back at the time. So she publicized that, the Washington Post and other outlets picked up on it, and it resulted in a huge public outcry against it. That coincided, interestingly enough, with Sonny Anand's paper in the New England Journal of Medicine around 1987. So the stage was set for a complete about-face on anesthesia for newborns at the time. We don't have anything analogous to that. And I'll point out, even at that time, even 15 years later, it was still not universal. So by the early 2000s, it had become pretty much, it was the standard of care for newborns to receive anesthesia. Also, the same thing with animals, okay? So animal pain was in the same situation as premature infant pain in the mid-80s. So animals also did not receive anesthesia for their invasive surgeries at that time. So those are two groups of creatures that we agree almost universally require anesthesia now. And abortion is the only time when we don't give it to babies.
That's really amazing when you think about it. And it's funny because it's strange to think that they can feel pain. We know that now. Well, we know that there's a strong possibility that they can feel pain. We don't know how much pain, right? But we should at least consider the possibility. Let's put it that way. And that taps into their humanity, of course.
Yep.
But what you don't see, I think you see now in unborn animals that sometimes they need procedures, or they need to be, sometimes abortions have to be performed on animals. In farming, for instance, and I see discussions about anesthetics there, and it's very interesting that when it comes down to even bird eggs, sometimes we have in the Netherlands, in certain areas, nature areas, we have some birds that are protected, and their eggs, but their population needs to be controlled rather. And then they used to smash the eggs. The people, the forest workers. Now they can't do that anymore because they don't know how far along the fetal tissue is, basically, and so then for moral reasons they don't do it that way anymore, so they inject it with something. It's very odd that they have all these considerations for animals, which is nothing against that, of course, but no considerations at all for the unborn human beings. So yeah, it's very strange to me. Another thing I wanted to ask you is there's been some discussion on whether or not abortions already are sedated for the child in some sense. For instance, there are people saying, well, especially in later term abortions, second term abortions, the woman can choose to have full anesthetics performed on herself, which then in turn is enough for the fetus to also be sedated. What's your response to that argument?
Yeah, it doesn't seem to be. As far as we know, not enough anesthetic crosses the placental barrier for the fetus to become fully anesthetized. Certainly not to the extent that he or she would not feel anything as she were being torn apart in the womb.
Right.
So we do see this, sometimes, when the mother is anesthetized and the baby's born in a regular childbirth, the fetus or the newborn child wakes up crying. We don't want to give too much anesthetic to the mom for her own. I think the point is to get the amount needed to cross the barrier for the child to be anesthetized. It would be dangerous for the mother to receive that amount of, for example, opioid anesthetics.
Right.
So the answer is no. It does not seem to be the case that that general anesthetic for the mom would be sufficient for the baby.
Right, because otherwise, when they do therapeutic, like real surgery on an unborn, they would just simply anesthetize the mother. But they also actually separately anesthetize the child. Now, speaking of those surgeries on unborn children in order to help them to fix something in their heart, for instance. Some would say, well, they use the anesthetics to immobilize the child. Yes. And that's, of course, true. But is that the only reason, or is there also a clear reason or a consideration for the child not having pain or at least a stress response, is what I've heard?
Right. Yes, stress response. This was, by the way, the same reason they gave for, they would use anesthesia. If they did use anesthesia for animals, they would say it's just for immobilization. It's not for pain. To which some people replied, well, that's ridiculous. Why would they need to be immobilized if they weren't in pain? It's a fair question.
Okay, yeah.
In 2005, the Journal of American Medical Association published an article by Lee and colleagues. That's very famous. You may have seen it. I'm sure you have seen it cited around the fetal pain debate that addressed this very topic. It said, well, we only anesthetize them not for pain, but for immobilization and for future considerations. For example, the fetus, when born, if we don't anesthetize the fetus during these fetal surgeries, the child in later years may develop some psychological difficulties in response to the trauma of receiving surgery as a fetus. Right. So I found it very interesting because they're saying we don't anesthetize for pain now, we anesthetize for pain later. Doesn't make any sense at all.
Right.
And also I would say, well, if you're anesthetizing for immobilization, then why not just use Pabulon or one of those other paralytics that you used to use universally on newborns and animals, which is sufficient. They used to just perform open heart surgery, even the most invasive surgeries, giving just a muscular depolarizing agent, Pabulon or something else, and oxygen. That was it, because they said at the time, well, number one, the fetus can't, or the newborn can't feel pain, and the animal can't feel pain. And by the way, this is too dangerous to give them these anesthetics. So why not just give them that? And I think the answer is clearly that they are actually feeling pain.
Yeah, or at least they feel the the need to be precautionary, to have a precautionary rule. And I've always found that an interesting take. Myself, when I studied this topic, I always thought, okay, even if we don't know if pain is possible, if the experience of pain is possible, given the evidence we have so far, we should have how do you call it, the precautionary rule, as you might say, to say, well, since we don't know for sure, let's be careful, because the alternative is not being careful and actually hurting millions of babies worldwide, or unborn babies, basically. So another one of those arguments was, and this was actually a bit of a Twitter storm a few years ago, I think, is when an MD called Leah Torres, do you know that name? She said that she cuts the cord before, so they don't feel pain because she cuts the cord. Now, a lot of people thought, that she meant the umbilical. How do you say that in English? The
cords. Yep.
The vocal cords. Yeah.
Yep.
So that became a big storm kind of on Twitter, and she got a lot of unfair criticism. But what she actually meant was the umbilical cord.
Yep.
And so since that argument is also going around, that if you first cut the umbilical cord, then there's no more capacity to feel pain, if there ever was. What would you say to that argument?
All right. So thanks for giving me an opportunity to address that. Actually, a few days ago, Chris posted a thread to Twitter addressing this very topic, because it keeps coming up and it won't die, it won't go away. We keep bringing that up and throwing it in Dr. Torres' face. Now, I agree, she's a very, how shall we say, fairly aggressive debater, advocate of abortion online and in the print media. So I don't blame pro-lifers for being angry at her, but I think this is counterproductive. There's plenty of horror of abortion to address without making things up and throwing them back in their face, resurrecting things, as it were. So this is a non-issue. But here's the idea, I think, behind her statement. Cutting the umbilical cord, transecting the cord, is a fairly well-known within the abortion community way of affecting fetal demise, which is a term for killing the baby before you dismember it, dismember the child. Yeah. The idea is that the baby will bleed out from the umbilical cord, and that will affect her death. And then you can do whatever you want to with her. She's not going to, for example, I think this really came about after the partial birth abortion bans in the United States, where it was illegal to kill the baby. They used to, stick the scissors, the Mayo scissors, at the base of the skull, and suck the brains out, or disrupt the brain tissue to kill the baby after the baby was halfway born, like the legs and so on were. So I think so to prevent that, they said you can't deliver a live child. You have to kill the child in the womb. So I think this is where all this came from. To bleed out the child in the womb it takes minutes, but it's presumably affecting fetal demise, killing the baby, and also preventing any screaming or possibly any pain before abortion.
Right.
So remind me of your particular question, because this is a pretty big topic lately. I kind of
well, the question is, how would you counter the argument that they cannot feel pain because they first cut the umbilical cord?
Okay. So the cord itself is not innervated. So if we poke the baby with a needle, the baby will respond vigorously, physically, with increased heart rate and breathing rate and aversive actions. But if we poke the umbilical cord, the baby does no such thing. The baby doesn't feel. So when we cut the cord, the baby doesn't feel it. Now, the only question is, does bleeding out cause the baby any pain? And it's hard to know the answer to that, but I would say if we bleed out, we may feel a lot of stress and anxiety as we do it. As far as we know, that's what adult humans feel. I think it's no less reasonable to assume that the fetus, if the fetus is developmentally capable of feeling anxiety, that the baby would feel anxiety, panic, stress, and so on as she's being bled out.
Yeah.
on the scale of death by dismemberment or death by exsanguination, bleeding out, I would choose the latter, not the former. That's all I can say about that right now.
Right. Okay. Well, that's very interesting. So there are a lot of arguments out there that say that, they work around it as if they already know about fetal pain and they've taken precautions, which is it seems a bit disingenuous to me, because it's not like they're cutting the cord for that consideration at all. It's just how they work. They sort of work their way down, if you want to put it that way.
It's like hedging their bets. It's like anesthetizing, not for pain, but for immobilization. So the reason given may not always be the real reason or the sum total of the reasons. Yeah, so I agree. It may or may not have anything to do with pain, but the reason they give is not pain, but they may be having that in the back of their minds. Who knows?
Right. Now, if we could go back to the essay that you wrote with Stuart Derbyshire.
Yep.
In the essay, you both agree that now we can say that we should accept the possibility of fetal pain experience from 18 weeks, but possibly even 12 weeks.
Yep.
But that's the science of it. That's basically the science saying that that's now a possibility that we must acknowledge. But what is the conclusion? You both had different conclusions, if I remember correctly, about whether or not the practice should now change.
Yep.
You were clearly on the side of, well, this sort of forces abortion doctors and all doctors involved with unborn children to take these precautions. And I think Stuart Derbyshire was more of the opinion that it's possible to do that, but that should be up to the woman and her doctor, possibly. Well, you've spoken to him many times, of course, and you both wrote this essay. So why do you think you both have different conclusions based on the same facts?
A good question. And let's just say that I'm sympathetic to his position, because I'm a government type. I think that anything the government puts its fingers into, it risks really screwing up, and it's not likely to reverse course on it. So it's only likely to get worse if we start out on doing the wrong thing. It's not going to often be reversed. It takes a lot of effort to reverse the momentum. So I'm sympathetic to him there. He wants to keep it small. But I would say that we have good evidence that there is fetal pain, and we also have good evidence that abortion providers don't want to address fetal pain or even acknowledge it.
Right.
So where do we go from there? I mean, if we're a sensitive, caring civilization, then we ought to. I mean, we treat pain in every invasive surgery except that one. So why not? And I think it's because we're stubborn, frankly, and we're human beings. And once we get a hold of something, we don't want to change our position. So that's where the legislation comes in. I think it's reasonable to consider legislation. And in fact, we in the medical field have a long history of doing things exactly as we want and refusing outside interference. That's the whole reason why we have informed consent laws in the United States and around the world, is because doctors, when their patients were anesthetized and under surgery, would find something else to do, and they just do it, and the patient would wake up and be like, "What'd you do, doc? I told you to operate on my left ear. You operated on my right ear. That's not what I wanted." Right. And much worse, incidentally. So that's why we have medical legislation. Medicine is one of the most highly legislated fields in the world, if not the most highly legislated. I think it's with good cause. So I think that this is one of those times when the force of the law can be brought to bear fruitfully on this topic. And I will admit that it's exactly incommensurate with the purpose of abortion, which is to kill the child. So concern for the child's well-being through anesthesia is exactly the opposite of our complete lack of concern for the child and abortion. So there's a huge tension being brought here, and it's very much in the vein of what Martin Luther King used to do in the civil rights era, where he would just show the disparities, what we claim to care about versus what we actually care about. And so fetal pain laws would kind of dramatize that and bring it to light. And I think this is no different.
Right. So one very short thing you said in there was why not? And to be fair, what would be against using it? I mean, it's not the cost. Could it be that it's problematic for the women undergoing the procedure? Is it an extra type of medicine that they maybe not respond well to? What could be the reasoning of not doing it?
Sure. Probably the number one reason given for not administering fetal anesthesia to children undergoing abortion, being the target of abortion, is the concern for the mother. They say the woman, or the whatever the term is these days.
Yeah.
So, and that's fair. That's fair. And it would hold more weight, first of all, if the proponents of abortion weren't so committed to developing all sorts of new techniques for abortion as they have in the past. I mean, every one of these techniques of abortion was theoretical, or it was just somebody had to try the first thing first, and they weren't really, it wasn't like they had rigorous controlled trials for all these abortion techniques, whether saline abortion or even D&E, DNX, all these different types of abortion. These were all experimental when they were developed, and it's not like they had rigorous controlled trials. Some guy, usually a male physician at some time, just tried it. And by the way, they were doing these with non-medical providers in any sense back in the days before Roe v. Wade. They were just having James, they called them, people who were taught by somebody to do abortions, doing abortions. So this whole concern about the well-being of the woman, the mother, is not really. It's a reason given, and it's legitimate, but it doesn't have a whole lot of moral force,
right,
from the people who are delivering it.
Yeah.
So I don't know. That's what I'd say for now. But also, there are also pretty non-invasive ways of affecting fetal anesthesia if we really want to get into it.
Okay. Well, another thing that I just thought of is abortion pills. Now, you would say that this doesn't have a link to this discussion because in most Western countries, I believe, most definitely in the Netherlands, abortion pills are not used after 9 weeks. This is actually the rules in the Netherlands state this. And but I've seen internationally, if you look at some of the documents by, I think, Doctors Without Borders, but also the World Health Organization, they do find it acceptable to use abortion pills beyond that week of pregnancy, sometimes even beyond 24 weeks. So then the abortion pills would actually come into the discussion of fetal pain in those cases.
Mm-hmm.
And, how does that play out? Because what does an abortion pill do? I understand this is not your field of expertise probably, but what does the abortion pill potentially do to the child that could cause it to become pain? Does it burn it or something? It's an unclear method basically.
Right. Yeah, good question. Again, it's not my area of expertise. I'm a generalist. I'm a PA, but my understanding is it thins the uterine lining, make it an inhospitable place for the fetus to attach via the placenta. So it deprives the placenta of nutrients, oxygen, and so on.
Right.
So it basically disconnects in the source of oxygen and nutrients, the umbilical cord placenta unit. So could the fetus feel pain? It's sort of like, the way I envision it would be something like a very slow version of exsanguination. It's starvation, suffocation. And I have no idea what the fetus of a given gestational age would feel from that. I don't know if it would be, I suspect that that it's more humane than ripping the child limb from limb. Let's put it that way.
Right.
But I don't know. It's hard for me to really hypothesize what the fetus would feel.
Right. Well, the interesting thing you said earlier about, the considerations, the sort of the paradox of, using anesthetics for the unborn right before you viciously, pull it apart in an instrumental an abortion. That is kind of a paradox, but my understanding of the pro-choice philosophy as it came about in the 1970s is one that actually acknowledges the humanity of the unborn. precisely because they needed something to take that whole discussion about the humanity, whether it is a human being or not, out of the whole equation. Because, well, the way I see it, they kind of knew that that was a losing game, because science, in the field of embryology was so advanced by that time that there was really no discussion concerning the question, is it a human being? It is a human being from conception. And so they had to basically acknowledge with their examples and with their hypotheses that yes, it is a human being. Let's say that, and then still you could kill it. So potentially, I'm not saying that this is for individuals. This is the case, for instance, abortion doctors. But potentially, the pro-choice philosophy has the capability of seeing the child as a human being, and so then the paradox is sort of even greater, of caring for it before you kill it, knowing it is a human being. So basically, my last question would be, what would you say to some of those pro-choicers? Just maybe, anyone, they don't have to be an abortion doctor necessarily. What would you say to them if they considered this topic of fetal pain? How would you defend unborn life in their humanity, given the fetal pain issue?
That's a tough question, Chris, because once we allow legal abortion, any restriction of that just doesn't seem to make any sense. Because legal abortion is an absurdity on its face if we consider human rights to be paramount. Right. But once we enable legal abortion, then human rights becomes absurd. So it's a real tough juxtaposition. There's a big paradox, real tension there. So I don't really know. At some point, I think people aren't being real if they think that we can dispense with human rights in some cases, but not in others. And I think that they haven't really thought through. Their understanding may be superficial. And I say that with a lot of sympathy, because frankly, there's a huge effort out there from a lot of elites to minimize the importance of human rights in these cases and sort of maximize them in others. Right. And so I don't know what I would do. I think my main approach in these cases is to ask questions, understand where they're coming from and why they think what they do, and not try to go all out on arguments and debates, because it's unlikely to be effective. What I really want to do is understand what my opponent, my interlocutor, is where they're coming from. If they can articulate it, they can tell me, and then we can have a fruitful discussion. So frankly, they're less likely to listen to anything that I have to say if they don't think that I care what they have to say. That's how I would start it.
Well, that's a really good answer, and I think we can use that as pro-lifers back home to incorporate that into our discussions with people. And so we've come to the conclusion of today's podcast. I'd like to thank you very much, and I hope to maybe ask you again for another interview if we have something new that comes up. I know that there are some interesting things going on in Great Britain, for instance. So, but thank you for now, and I will address the Dutch audience now to sort of close off the podcast. Oké, jongens, dit was het. Ik hoop dat jullie hiervan geleerd hebben wat voor verschillende meningen er zijn in de wetenschap over fetale pijn en wat de meest recente bevindingen eigenlijk zijn. En dat die eigenlijk meer naar een pro-life kant toe gaan dan naar een pro-choice kant, zou je kunnen zeggen. Kijk uit naar de volgende keer wanneer ik weer iemand zal proberen te interviewen of een presentatie geef. En voor nu een hele fijne dag.